Thank you for standing by. At this time, all participants are in listen-only mode. For the discussion, there will be question and answer. To ask a question, please press star and then the number 1. And this is being recorded. If you have any objections, you may disconnect at this point. Meeting over to your host, Mr. Greg Poe. You may now begin.
Thanks, Joseph. Welcome to the American Heart Association Midwest Affiliate Atrial Fibrillation webinar. Greg Poe, the Director of Quality and Systems Improvement for the state of Indiana, and we're pleased to bring you this webinar. We will look at important variables associated with the treatment of atrial fibrillation patients, the prevention versus medical management. Our guest presenter is Dr. Gopi Moody, Medical Director for Indiana University Health Cardiac Electrophysiology Department in Indianapolis, Indiana. Dr. Moody is the Program Director for IU Health's Atrial Fibrillation Center, as well as a Clinical Assistant Professor at the IU School of Medicine. Dr. Moody, welcome.
And thank you, everybody, for joining us today during your lunch hour. The purpose of this talk is just to give you an overall view about atrial fibrillation and its options. And in the end, I'll highlight how do we approach atrial fibrillation at our institution at IU Health. Hopefully we'll finish this in the entire hour so we have time for questions at the end. We look at atrial fibrillation as a chronic health disease rather than just an arrhythmia. That's something that we teach all of our nurse practitioners as providers to start looking at atrial fibrillation just like high blood pressure and diabetes rather than an arrhythmia. The arrhythmias that we deal with, such as nodal reentry tachycardia and so on, are easily curable diseases like atrial fibrillation, which is a chronic disease. So atrial fibrillation affects more than 1/3 of the patients with any age greater than 80. Up to 2% of these patients are between the range of 75 to 84. And as this grows, we're noticing more and more younger patients being diagnosed with atrial fibrillation and requiring treatment. Even though it's associated with structural heart disease, other chronic conditions, there are also patients with lone atrial fibrillation without any other risk factors that we see nowadays. Important probably aspect of atrial fibrillation is the fact that it's associated with a 5-fold increased risk of stroke. That risk increases with age. And importantly, stroke that is associated with atrial fibrillation tends to be more severe and larger in terms of bulk of stroke compared to AF-related strokes. It's also with the threefold risk of heart failure, and there's some recent data to show the utility of ablation therapy in patients with heart failure and atrial fibrillation. And there's also increased understanding that there's a risk of dementia and overall mortality. The Cabana trial did show this mortality benefit from AFib ablation. Patients with AF as a primary diagnosis are close to 500,000 annually, and this is probably an underestimate. It contributes to at least close to 100,000 deaths per year. Again, this may be an underestimate, or sometimes it's hard to judge whether an arrhythmia was actually a major cause of it because it coexists with a lot of other comorbid conditions. AF are also hospitalized twice as often as patients without atrial fibrillation. They're more likely to have multiple admissions, and 2% of the patients with AF die in the hospital compared to minimal patients without it, so 0.1%. So there's a significant difference between the cohorts. Estimated that treating patients with AF adds anywhere up to $26 billion to U.S. healthcare bill annually. Interestingly, we spend a lot of resources on heart failure, and the heart failure data suggests about $35 billion. So you can imagine atrial fibrillation being a major cause of cost in the U.S. healthcare. As we know, again, this is a very wide range. About 2.7 million to 6.1 million American adults suffer atrial fibrillation. And clearly, the trend is that this is expected to at least double over the next 25 years, not only within the United States, but globally as well, adding to the cost burden. Understand some of the definitions. A lot of these definitions can be quite confusing. They're confusing to us as electrophysiologists as well. A lot of these are defined primarily for clinical trials. From the practical standpoint, they can be actually quite confusing. But for all intents and purposes, paroxysmal atrial fibrillation is any AFib that terminates spontaneously or without any intervention, or with any intervention within 7 days of onset. So somebody who's cardioverted within 7 days of onset, they're considered paroxysmal. If you exceed 7 days, by definition, is considered persistent atrial fibrillation. Even though you may cardiovert that patient on the 8th day and they go back into sinus and they maintain sinus rhythm. You can understand why this is confusing, because that patient is behaving like somebody who has paroxysmal atrial fibrillation, even though by definition in clinical trials we call that patient persistent atrial fibrillation. It can all vary in frequency. Persistent atrial fibrillation is an AFib that continues beyond 7 days, no matter what intervention you offer. And it lasts greater than 12 months continuous. We call it long-standing persistent atrial fibrillation. There's a definition that's been defined called early persistent atrial fibrillation. That really entails that somebody has AFib up to 2 months in that persistent phase. It distinguishes it between persistent versus long-standing persistent atrial fibrillation. Part is something that we all decide that we're not going to do anything about the arrhythmia itself in terms of sinus rhythm. So it would be a 50-year-old where you've added due to all of the comorbid conditions, you're leaving them in AF, or somebody 90 years old, where we decide to medically treat him in terms of rate control. And it's pathophysiology-based. So when we define these, we're not really defining pathophysiology, although we understand that if somebody has persistent AF, the pathophysiology is different than somebody with paroxysmal atrial fibrillation. And it's important to understand these definitions. Really, a lot of the therapies that we guide in terms of anticoagulation, risk factors, and so on are in the non-malleable atrial fibrillation. Most of the studies have been done in this setting. It's really the absence of any kind of significant mitral stenosis, use of mechanical bioprosthetic heart valve, even though that can be a little bit muddy sometimes, or valve repair. Additional risk assessment for anticoagulation using the CHADS-VASc score. We've essentially, I think more or less everybody has moved towards the CHADS-VASc score. It's more sensitive because it adds more risk factors to detect risk for thromboembolic events. And when we start exceeding more than 1, we consider it somewhat of a moderate risk, and anticoagulation is usually offered to patients. And a little bit about anticoagulation indication. So it's a class 1 indication. If you look at current guidelines, the CHADS-VASc score is recommended. See, with mechanical valves, there have been studies now showing, at least one study showing the ability of using the novel anticoagulants. So warfarin is still recommended for mechanical valves. And greater than 2, so I say usually 1, because once it falls into 2, where we start anticoagulating patients, or prior to stroke, regardless of their risk, RTA, oral anticoagulation, is recommended. So patients can include Coumadin versus direct thrombin inhibitors versus factor Xa inhibitors. It's important that renal function should be evaluated at baseline and as needed. So one of the things that's not uncommon is an 80-year-old with baseline renal function that's somewhat borderline. We start these anticoagulants, and they develop diastolic heart failure and renal function changes. It's important to pay attention to that carefully, because doses may need to be adjusted based on renal creatinine clearance. Also, we don't make any distinction between atrial flutter and atrial fibrillation. They both are treated the same way from an anticoagulation risk standpoint or a thrombotic risk standpoint. In the group category, non-malleable AF and CHADS score of 0, it's okay to skip the thrombotics. So the score of 0, more or less, most of us don't anticoagulate patients. Once you're getting to a score of 1, you can discuss the aspirin versus anticoagulation in this case. We'll talk a little bit about aspirin in just a bit. It's okay to continue oral anticoagulants with Plavix and without aspirin. So this is usually our standard practice here at our institution. And class 3, where there's no benefit, stage renal disease or hemodialysis patients, dagatron or roxaden are recommended, especially with the mechanical heart valves, dabigatran has been shown not to be beneficial and even harmful as well. For use, which is very controversial, you'll see guidelines recommending aspirin. You'll hear guidelines saying the data is not that good. So if you look at overall data with aspirin, data is actually quite poor to support the use of aspirin. There's a randomized trial, the SPAF trial, showing any benefit at a higher dose. The trials showed no benefit. What about the use of antiplatelet therapy, such as Plavix and aspirin versus aspirin? So if you look at the active trials, adjust warfarin for stroke prevention was significantly better than Plavix and aspirin. So clopidogrel and aspirin are not a substitute for warfarin. It's not uncommon that we see patients where they're told that since they're on these drugs, they don't need to be on warfarin. It is not a substitute based on the clinical trials. And clopidogrel plus aspirin is somewhat superior to aspirin alone, but you really have to balance the risk of bleeding when you add Plavix as an anticoagulant for atrial fibrillation and warfarin. Therapy, I'm an electrophysiologist, so ablation has become the cornerstone of therapy for atrial fibrillation. Discussing about the Cabana trial that was recently published is the 3 hours worth of information. So just based on current practice patterns and recommendations and guidelines, even in the setting of the Cabana trial, it's a class 1 indication for symptomatic paroxysmal atrial fibrillation. They're refractory or intolerant to either a class 1 antiarrhythmic agent or a class 2 antiarrhythmic agent. So class 1 would include your fluoride or propafenone. Class 2 would be your sotalol, dofetilide, amiodarone, and so on. When a rhythm control strategy is desired. And it's also a class 1 indication prior to consideration of AF ablation. Assess procedural risks and outcomes to be discussed. So again, the shared decision making before subjected to an ablation procedure. Or is a class 2 indication where it is reasonable to offer AF ablation in selected patients with symptomatic persistent AF that is refractory or intolerant to class 1 or class 3 agents. So you can hear specifically saying for a 2A indication that should be trying an antiarrhythmic agent as a first-line therapy for symptomatic persistent AF. It also 2 indication in patients with recurrent symptomatic AF, where ablation is reasonable as an initial rhythm control strategy prior to therapeutic trials of antiarrhythmic drugs. Again, after having a shared decision-making about the risks and benefits of an ablation procedure in this case. B indications, once go past this paroxysmal to persistent and long-standing persistent, starting a 2B indication, especially if they've been intolerant to antiarrhythmic therapy in the past, where a rhythm control strategy is desired. And also be considered prior to initiation of antiarrhythmic therapy with class 1 or class 3 agents for, again, symptomatic persistent AF, against a rhythm, where a rhythm control strategy is desired. So really, paroxysmal symptomatic patients, it's unreasonable, especially if they failed an antiarrhythmic therapy, to offer ablation therapy instead of another antiarrhythmic agent and an antiarrhythmic agent that actually carries class 1 indication. When start going from paroxysmal to persistent to long-standing persistent, it's the indication is less as a first-line therapy that we should document probably a failed antiarrhythmic before you proceed with that. Also, it would be important that the patient preference should weigh into this considerably when making this decision. What's important, if you think about drug therapy, I don't have a slide here. Initial drug therapy is effective in about 60% of patients or so. Over time, the efficacy of drug therapy wanes quite a bit to the point where we usually, over time, it's less than 20% effective in the long run. So we have failed treatment patients and also treatment-effective patients who become ineffective over time. So there's a significant population out there with symptomatic atrial fibrillation that probably is not carefully assessed for all the therapies that are available, including ablation therapy for management of atrial fibrillation. Important for us to understand this because as we talk about, again, I give examples to people when I discuss this, somebody with hypertension and diabetes, that you're asymptomatic and let's wait for 5 years for you to develop disease and then we'll start treating you. As a matter of fact, we start identifying people as pre-hypertensives and pre-diabetics and start aggressively treating. Atrial fibrillation is a chronic disease where the left atrium, the right atrium, and the cardiac tissue itself undergoes a lot of rehealing over time. That's why you have different progression of disease over a period of time, going from paroxysmal to persistent to long-standing persistent to permanent. So the whole point of the approach to management of atrial fibrillation is how to arrest that disease process. So the earlier you identify, the earlier you treat these patients, the higher the likelihood, at least if you look at all the data, that patients will do better with the therapies that we offer. This is just showing that what percent of patients who are actually properly screened who are eligible for aggressive therapy don't actually get aggressive therapy in terms of ablation therapy. Treatment options, clearly we know pharmacological therapies, there's the rate control, there's the rhythm control with antiarrhythmics, and of course cardioversions. Important to understand, cardioversions are a short-term fix. They help you restore sinus rhythm. They don't help you maintain sinus rhythm. A little bit about surgical therapies. Obviously, some of you may have institutions where you're doing convergent procedures. In our institution, we're primarily a catheter-based different energy sources. Not only is there radio frequency and the cryoablation, now there's laser, there's also high-frequency ultrasound. So the different energy sources and how you want to create that scar. So overall ablation success rates over time since 1994, when Michel Asker and Bordeaux group described pulmonary vein isolation. Our procedure has evolved significantally. When I first started out during fellowship, some procedures lasted 9 hours. Today, it's common to go past 3 hours. Majority of our procedures are 2.5 hours. Also, success rates have increased partly because of understanding how to deliver lesions better, how to deliver transmural lesions, having better technology, and so on. Our success are usually, at least short term, when we talk about success rates, there's a short term, which is maybe 1 to 2 years, and long term, which is 3, 4 years down the road. It's great 80% at this point. That's what most of the data suggested recent trials. This NAF success rates are lower, and it tells you something about the milieu and the disease process itself, 60 to 70%. So our approach here is to identify patients early on in the disease process, such as when they have paroxysmal atrial fibrillation, and offer these therapies rather than wait for a disease to progress and get into this persistent mode. About 5% of patients still require we do AF ablation at some point. We discussed that. That point can be 6 months down the road, or it could be 3 years down the road. It's quite variable depending on the patient. And some recent trials, I didn't include Cabana in here, but the Castle AF, which showed morbidity but mortality benefit when AF ablation is performed in patients with cardiomyopathy. And these are significant cardiomyopathy patients with ICDs who benefited. And we always knew that physiologically it makes sense in somebody with a cardiac output, especially if they're in atrial fibrillation, restoring sinus rhythm, should improve their overall outcome. But it was a trial that showed actually mortality benefit. And this old slide, obviously we all know the Cabana trial is out. It's its own positive and negatives. Again, that's beyond the scope of discussion for this talk today. So just to switch modes here, how do we look at atrial fibrillation at our center here at IU Health? So if you represent yourself as a center for ablation, really limiting patient contacts, because somebody's screening all these patients for you saying this patient is not appropriate for ablation or this patient is not appropriate for advanced therapies, ever really get the patient involved in your center. It's not uncommon, at least in our institution. Physicians are really unsure when to refer patients in many instances. So even among radiology colleagues who manage patients with atrial fibrillation, when the right time, should we try another antiarrhythmic agent? Should we just leave them alone? Should we cardiovert and wait for 6 months? In the meantime, they have recurrence. Should we just rate control, or should we rhythm control? So a lot of, again, everybody's experiences are different when it comes to management of atrial fibrillation. Finally, a lot of them are confused as to should be aggressive. Should we be aggressive in restoring sinus rhythm in an 80-year-old with diastolic heart failure? Should we do it with somebody with COPD, long-standing COPD? And now all the drugs that we have available, forget about arrhythmics for a second, we talk about anticoagulants. There are several coagulants which have some specific role in specific patients. You have to be careful about renal function and so on. How to get the right drug for the right patient. And again, finally, antiarrhythmics, which is very common. We see it even within our own practice. Some cardiologists are very comfortable giving amiodarone. They're incredibly uncomfortable giving a drug like flecainide, which works incredibly well for paroxysmal atrial fibrillation. They're very comfortable giving sotalol, but they're very uncomfortable giving a normal dose sotalol. It's not uncommon to see 60 to 80 milligrams of sotalol in patients, where the higher the dose, the better the efficacy. Similarly, when patients are loading patients into fenolide, it's uncommon that people are worried and they cut the dose significantly, and patients go home on relatively low doses of dofetilide, which again is going to be dose dependent in terms of the efficacy of that drug. So being a comprehensive center addresses all these issues, takes away that decision making that's quite complex at the PC level and even at the cardiology level, and really puts it solely in this center where, seeing electrophysiologists approach this. Again, it's important to approach this as a disease process rather than just a purely an ablation. Can really add a whole lot of value to your system. So it's no different than what we have as valve clinics, heart failure clinics, and lipid management clinics. We've never really thought about atrial fibrillation like this because development of EP until recently, it's been more of an ablation strategy rather than a long-term treatment strategy of patients with atrial fibrillation. So something that I show, this is how we approach in our system. Again, if you look to the right where you have rate and rhythm control, primarily the referral base that comes to us are considered the bottom half where you do the cryoablation or you do RF ablation, different of ablation and so on, or you revert them and put them on antiarrhythmics. But you can see what else is left here in management of atrial fibrillation. Anticoagulation risk. How to better assess them, anticoagulation and the risk of what's the right drug and what's their risk. We use pharmacists in our system to help with make that assessment. We have pharmacists follow these patients carefully, especially if renal function is changing and so on. What about long-term monitoring, such as LR, or whether people use a live core, or whether people use periodic event monitoring? How do we manage these patients, especially patients such as those with tachycardia-induced cardiomyopathy? It's not uncommon nowadays to see younger patients presenting with a mild cardiomyopathy and some even severe forms of cardiomyopathy, making the assumption that somebody has a non-ischemic cardiomyopathy when all they have was induced cardiomyopathy. TD syndrome patients, for example, not again uncommon in an 80-year-old who's on 2 or 3 drugs for rate control. You're preemptively looking for brady episodes and doing these kinds of monitoring and picking them up way up front in the disease process rather than presenting with near syncope or syncope with injuries. Now, atrial appendage occlusion devices. So we do a better assessment of who's candidate for it and do they qualify for it. So we offer these upfront in the higher risk patients. Again, it's not common where patients are referred for these until they have a stroke. So how to mitigate all those kinds of events, and the better way of doing that is in this kind of a comprehensive center. Trials. One of the advantages in a big system of having this kind of a clinic and a center is all these patients are really touched in this clinic. Now you have this huge database of patients with all forms of AFib, from paroxysmal to persistent, long-standing persistent, young, old, ablation, non-ablated patients, and so on. Gives you a good resource to actually do important clinical trials to understand the disease progression and therapies that are offered. And really, most importantly, risk reduction. So we nurse practitioners who run our AFib clinic and are with physicians, and they have the luxury of having the ability to spend at least an hour with patients. So things we discuss is risk reduction, such as treatment of hypertension, obstructive sleep apnea, weight reduction, so on. We become the largest referral now, our center, for sleep apnea study or obstructive sleep apnea in the system. Almost, I would say, 70 to 80% of our patients end up getting a sleep study. Probably 60 to owing to where we live here in the Midwest, end up having sleep apnea. And in that, we have the highest chance of convincing patients, because now they want treatment for atrial fibrillation, of using their CPAP machines on a regular basis. And we've had some incredible stories of patients with weight loss, just because we're able to pack the whole thing as a chronic disease and stress the importance that ablation is not the end-all, be-all for this. Risk reduction and so on is also part of the process of treatment in the long run. So just 3-4 examples here of how we assess patients. So we more or less create a profile. So this is an example of a 76-year-old female. These are all real-life patients with newly diagnosed atrial fibrillation, high blood pressure with systolic blood pressure of 165 millimeters of mercury, has a prior history of GI bleeding requiring transfusion. So it's not common, 76-year-old with prior bleed. People say, absolutely not, we're not anticoagulating this patient, just put them on aspirin or don't anticoagulate at all. Maybe they may be referred for left atrial appendage occlusion device. If they have PAF, and most of the time they're in sinus, they may not even be referred for that. The patient's heart rate is 100s, fatigue with exertion, EF is normal, and in this case, the patient is on aspirin and metoprolol, 25 BID. This patient was managed for about 6 months until we saw this patient. So with risk assessment, you use your blood score. Our scores are okay. They're not totally accurate in the sense that they capture every single thing, but over the population, they're not too bad. So in this case, even with the GI bleed, blood score is 3, and CHA2DS2-VASc score is 4. People have these discussions with patients, and when you have the discussion with the patient, you say, your CHA2DS2-VASc score is quite high in this setting at your age, and you've had a history of GI bleed, but your risk-benefit ratio, would you prefer to take anticoagulation and have the risk of bleeding, or do you prefer not to take anticoagulation and have a higher chance of stroke? And really, you'll see most patients saying, absolutely not, I'd rather take the anticoagulant. In this case, we're objectively assessing these patients rather than being subjective, saying they have a GI bleed, and saying their risk, the bleeding risk far outweighs, or at least outweighs their risk of stroke in this case. The anticoagulant, at least until recently, is now that we have reversal agents. We recommend warfarin instead of using one of these novel agents. So long experience with the novel agents in terms of catastrophic bleeds, but it's probably in the future we'll probably be offering novel anticoagulants as first-line therapy, even with history of GI bleeding and so on. And things we talk to patients up front is, in the future, if they have, again, further episodes or they're not intolerant to anticoagulants, they have future bleeds, left appendage closure device is a good option in this particular patient because of higher risk. And they can take short-term anticoagulation. These have been studied, left atrial appendage occlusion devices that take short-term anticoagulation. It's not in contraindicated patients with anticoagulation. But you can see how your discussion with the patient, which you would have never had if you go through something like this comprehensively assessing them. Particular case, now you have to talk about the atrial fibrillation itself. That was the bleeding risk. So clearly the patient is fatigued, the resting heart rate is fast, you ambulate the patient in the hallway, heart rates go up to 120, structurally normal heart with heart failure symptoms. So using beta blocker in this case is not an unreasonable option to look for rate control. Doing monitoring rather than just assumption that, hey, increase your drug, we'll see you back in 3 to 6 months and hopefully feel better. Actually setting these these patients on monitoring to look at how good a rate control you're achieving. So we can do all these things nowadays with monitors. What about AVG ablation? Let's say this particular patient is in long-standing persistent, doesn't want to be cardioverted. This monitoring actually gives us a good idea. What are their rates actually at home when they're doing activity rather than coming to clinic and resting on the table and checking heart rates? If they're not a good candidate for antiarrhythmic ablation, and they can't anticoagulation for whatever reason, then consider AVG ablation may not be a bad option. And so limiting your options of seeing these patients in the hospital after multiple admissions for heart failure and rapid rates, identify these patients way up front in the disease process and offer some of these therapies. In case we recommended follow-up with EP in 1 month in our AFIB clinic, assess rate control. And at that point, we also discussed left atrial closure device options as well. So early referral, where you're discussing all the options with the patient. You're not doing these in series, but you're actually saying these are all the potential options for you. So expectations are set up front. Patient actually understands there's a plan on how you want to attack these issues. And of course, aggressive offering better rate control strategies in this case, rather than increasing beta blocker dose and saying, we'll see you back in 6 months. So another patient, 56-year-old with paroxysmal atrial fibrillation for 2 months, no history, and she's normotensive. Symptoms are related to exertional dyspnea and fatigue. Echo normal. Resting heart rate is quite normal during AFib. Heart rate with walking is actually pretty well controlled with drugs at 82. All right, I'm not sure actually if the patient was on drugs, but you see in the patient completely comes into clinic, say, oh yeah, well maybe you're a little short of breath, but your heart rates are well controlled, your EF is normal, you ambulate, your heart rate's 82, so you really don't need much treatment. Let's just watch you for now until you get worsening symptoms. Blood score is 0. Risk of annual bleeding is 0.9% based on the score. HAS-VAS score of 1, 2% risk for stroke, low to moderate risk. Again, once you start crossing 2, we consider it that maybe this patient should be coagulated. In this case, we discussed patient was interested in the one and rhythm control strategy as well, so anticoagulation was recommended. And just simply saying the risk is very low, we don't need to give you any anticoagulation. This is a patient discussion. And in this, the renal function was normal, so with the NOAC, we thought compliance would be better. And patient rates well controlled, still continues to have symptoms. So what do we do from a symptomatic standpoint? Patient desires sinus rhythm, so we recommended rhythm control. So what are your options here? Again, we discuss all these options. Just cardioverting the patient is not going to be the solution in the long run. Again, it's a short-term fix. We do antiarrhythmics. Do we enroll this patient in a clinical trial? And there's some clinical trials that are looking at patients like this. So in these, she pursue cardioversion and antiarrhythmic, and that's exactly what we did as a first-line therapy. So months later, follow-up to assess symptoms. Because she was on a class 1C agent, we did a stress test in between. Again, we set expectations of what the progression of atrial fibrillation was. So we said, yes, there will be a good holiday period with drugs up front. You'll be responsive to it, but as time goes on, your response to drugs will go down. So that's when you know you're going to be right for ablation therapy due to symptomatic atrial fibrillation. And not only that, in some of these patients, because we do clinical trials and we're able to capture all these patients in this area, we're able to offer upfront clinical trials. Presenting a better strategy. This patient probably would have not been, if not referred, probably would have managed with rate control strategy. And you can imagine, again, disease progression over time. By the time they come back to EP, they're highly symptomatic. They probably failed 1 or 2 cardioversions. Some may have tried amiodarone. The left atrial size is increased significantly. And you're offering your ablation therapy saying that our success rates are not that good. And you want to be able to capture these patients early. Increase trial participation, which is very important as we understand AFib better and better each day. And also tailoring anticoagulants to patient and somebody young, instead of putting on warfarin, actually discussing all the options. Example of somebody with persistent atrial fibrillation, status post ablation. So we're doing simple rhythm monitoring because the persistent AF patient had mild form of tachycardia-induced cardiomyopathy. And you can see what early intervention does. So here's a patient with, Brady syndrome. So if you take these patients, especially as they get older and they have persistent arrhythmias, especially atrial fibrillation, and actually doing a rhythm control strategy with drugs. Drugs aren't benign. Just because at a point in time in clinic we see and they're in sinus or their rates are okay, it's very important to understand that as time goes, conduction system disease, as we age, we all have some degree of conduction system disease. So the drug we use to control rates and also rhythm can have adverse events as well. So long-term monitoring to some degree is quite helpful in these patients, especially in the higher risk patients, complain of dizziness and so on. So here's a patient that we picked up way up front. So imagine the same patient, syncope and a fall and a broken hip at age 85. So the ability in these kinds of clinics to follow patients long-term with monitoring. With this example, this is that I saw an 85-year-old female with permanent AF. She's on digoxin, metoprolol, and cardizem. She was being managed by cardiology by BP, saying that this permanent AF, we're rate controlling our 3 drugs, we can't really go up anymore, and let's just that way. So patient is feeling poorly, lacking energy, used quite active, and at this point when she presented, she was really, she couldn't even do laundry, couldn't lift a basket of laundry and go anywhere with it. Again, this is something that the patient has not presented with heart failure, has been admitted, so it never dawned on anybody to consider, hey, you know what, at 85 with 3 drugs and the drug toxicity and the fatigue maybe even be related to metoprolol and still getting adequate rate control, we should offer AVG ablation and take her off all these drugs. So we actually did AVG ablation, implanted actually a hispundal pacing, which is quite physiological. And 2 weeks later, and she's functional class 1 with absolutely no limitations, doing everything that she always wanted to do at her age. Clearly shows you what percentage of patients out there are like this that are being touched upon, where we can offer these kinds of therapies. So it's not always about ablation and so on. It's about quality of life. It's about offering the right therapy for the right patient, tailored to them specifically. So it's important, probably the most important thing you can get out of this is atrial fibrillation is a chronic disease. It is not just an arrhythmia. I think that's incredibly important to that and preach that to everybody in your communities, that we're seeing somebody with a chronic illness and atrial fibrillation is a chronic disease. It really requires a comprehensive management strategy, not just as electrophysiologists or cardiologists thinking about one strategy or the other, but you need to really look at the totality of it and say, what is the right strategy for this particular patient at this time? The younger you are, the more aggressive you tend to be. The older you are, probably the less aggressive you are. But there are patients at both ends of the spectrum where the opposite is also true, where some elderly patients derive significant benefit being in sinus rhythm. For symptomatic patients, it's very reasonable, especially very early in the disease process, because the outcomes are much better. Now, one of the things we didn't talk about in Cabana trial is Cabana is a mixed bag of taking paroxysmal persistent and early long-standing persistent patients and ablating all of them. We're still waiting for all that data, but if you look at all the current data on literature on ablation, paroxysmal symptomatic AFib patients do the best with procedures at this point. And doing this watchful waiting and let's see when things get worse, we'll do, is probably not the ideal strategy when you want to restore sinus rhythm in patients. As far as more importantly in the center, one do an ablation, let's say in our center, just in sinus rhythm at 3 months, 6 months, 1 year, we don't just sign off on them and say, hey, call us when you have a problem. We actually follow them as a chronic condition. These patients come to us long, as long as they're willing to follow up for surveillance for atrial fibrillation. And also risk factor reduction, as well as discuss about anticoagulants and what anticoagulants, maybe making adjustments to anticoagulants and so on. That should have probably 5-10 minutes to take questions.
All right, so can you open the lines for questions? He is doing that. That we did have a couple of questions that were to us ahead of time. And I'd like to offer Dr. Dan Moody one of them. I had the rate versus rhythm control in one of your case study slides and mentioned that it's about more than rate versus rhythm control. But one of the questions that we had, Doctor, was question, when is the ideal time, maybe ideal set of circumstances, to switch from the rate to rhythm control?
All right. So that's a very good question and a very valid question. Again, after the talk I described how we approach it. It's saying, when you look at it as a chronic disease, do I get tight control of my hemoglobin A1C or do I let it linger around 7? It's okay. When do I switch to get even tighter control? Really, control is from day one. So if you're going to see a patient and evaluate a patient for atrial fibrillation, I think it's incumbent upon you to decide, with that discussing with the patient, what strategy am I going to go in? I'm going to go rate control or rhythm control. What you want to do is say, I'm going to do rate control for the next 6 months to 1 year, and if you don't feel well, I'm going to do rhythm control. What happens over that period of time is disease progresses. And we all know that because we see, left atrial sizes of 5.5 centimeters with atrial fibrillation. So you're allowing disease to progress without breaking that cycle. So it makes sense to discuss upfront, either go a rate control strategy, and that's what we're going to accept for the rest of your life going forward, or a rhythm control strategy. And really use this analogy. I say we're going to throw the whole kitchen sink at you to try to keep you in rhythm. So it's important every single patient that you evaluate, you start thinking in those terms of, is this a control strategy long-term? Is it a rhythm control strategy long-term? And start offering those therapies up front.
Okay. Did you give the group the instructions on how to ask a question, please?
Absolutely, Greg. And thank you. Participants over the phone, we will now begin the question and answer session. If you wish to ask a question, please press star 1. Please unmute your phone and record your name clearly when prompted. Your name is required to introduce your question, and through all your requests, star 2. 1, please, for the first question, speakers.
Okay. Did also receive another question that may be entry, but still worth touching upon for maybe some of those in the audience. Is just to quickly just describe the relationship between AFib and stroke.
Right. So one of it's quite confusing in the sense that I'll do several examples. So the examples where people are newly diagnosed with atrial fibrillation, they get a TE and we actually see a left atrial appendage clot. So we clearly believe that in those cases, atrial fibrillation probably was the main reason why somebody had a clot, but that's the, and it means mechanistically. But there's a lot of patients that we have that have, for example, with strokes, and so we can interrogate the devices and see did they have atrial fibrillation in the last 1 month or 2 months and so on. And there's no real correlation that atrial fibrillation in the past 1 to 2 months that may predispose them to a stroke. So it's really a complex disease in terms of understanding. What we do understand is atrial fibrillation itself is a risk for stroke. Whether it's actually always a cause for stroke is quite controversial. It's like having risk factors for coronary artery disease, having risk factors for heart failure. AFib is a pretty significant risk factor. So that's why, for example, even though we do AF ablations, we implant loop recorders, and let's say somebody's CHA2DS2-VASc score is 3, you've gone through 1 year of monitoring and they have not had any atrial fibrillation, and part of their ablation they had a lot of AFib burden. Don't stop anticoagulation because we look at it as a marker for stroke in the long run. And plus, also we know that procedures that we do are not curative necessarily. For the most part, I call them that they're palliative because there's always a chance for recurrence as time goes on. So it's a complex disease that there's some clear correlation between atrial fibrillation causing strokes, but there is also a clear correlation in the sense that patients with devices who are monitored can have strokes in the set carrying a history of atrial fibrillation without documenting atrial fibrillation around the time of their stroke.
Okay. Thank you. Do we have any questions?
Speaker, at this time, we don't have any questions on queue. One, participants over the phone, to ask a question, please press star 1.
Do get some questions, we'll be sure and offer them to you, Doctor.
Sure.
You've been a tremendous asset to the Indiana Atrial Fibrillation Initiative, and a co-sponsor that with me. And what we're trying to do in that initiative is to really delve into answering some of the issues and starting up the programs and those kinds of things. As you start your program, you're a little bit more advanced in that. What are the aspects of starting an AFib clinic to your level or even in a lower level that give recommendations as must-have?
Sure. Well, first and foremost, whenever you start a program, you have to make sure you have the right resources to do it. If you don't have the right resources, these are bound to fail, and you're going to put all that effort and not have any results at the end. So one of the approaches that we made were, for example, worked our ER physicians. So we have created a protocol within the ER where we clearly define patients who can be actually treated for AFib in the ER and be discharged and be followed up in our clinic. These are patients because them is stressed in terms of not having enough beds, and the ER is always stressed in terms of holding on to patients and so on. So we've done a lot of education and family practice within our own system of discussing about all the therapies we have, and more importantly, giving access. The most important thing why any program works or fails is not having access to patients. So we were able to create a model where we convinced our system to give us a dedicated a nurse practitioner to start to do nothing but full-time AFib clinics. So Monday through Friday, her job is nothing but to see AFib only. She doesn't see any other patients in the EP world. She only sees AFib. So having that kind of access to build a program is incredibly important for sustain itself. And so creating our nurse practitioner is really good. Educate herself completely about AFib, spends the time and the resources with the patient to educate them. So we look at it as an opportunity to educate patient. It's not about just treatment options and discussing about procedures and all that. Our objective when the patient leaves in 1 hour is they're thoroughly educated about atrial fibrillation, better than even some physicians in medicine to that point. So that's the kind of granularity we're trying to achieve, because we want patients to drive their own care. We want them to understand the benefits of anything that we do and for them to be the proponents of what the next step would be in conjunction with us. So building kind of a population health kind of model where patients are empowered to understand what the disease process is and understand what the treatment options are and have them buy into it, I think goes a long way. So you have to approach it from a system standpoint of resources and finding, going and talking to the right people, and from a patient standpoint of making it a worthwhile experience for them when they come here to get educated in that 1 hour.
Okay. Well, thank you, Joseph. Have we got any questions?
At this time, we don't have any questions on queue.
All right. Well, thank you. You toss the presentation back to me by dragging the green dot to my name, please.
I think he was going to give it to you, I think. I don't see your name anywhere here.
Okay.
Is you,
I'll tell you what, Gopi, if you could advance
Sure.
the slide. Thank you, Doctor, for this presentation. It is absolutely outstanding, and we appreciate it very, very much. For on the phone, you know that the American Heart Association has over 15 years of offering quality initiatives for a wide array of cardiovascular and cerebrovascular diagnoses. We're proud to offer a robust program specific to atrial fibrillation. The AA encourages you to investigate how Get With the Guidelines atrial fibrillation program can significantly impact the quality of care your hospital can provide for your patients. Please visit www.heart.org on the professional header page. It's there that you may learn about all of the quality initiatives that AHA has, including atrial fibrillation. And Doctor, you could roll more slide, please. Dr. Phone. My apologies, but another way that you can learn about how to get involved with the atrial fibrillation initiative is contacting your local AHA director. And each of your directors I do have a slide, and let me regain control here. Okay. Fortunately, I'm not able to regain control, so we did have a listing of all your local directors. I think most of you are probably very familiar with who they are, and we'll get that information out to you. But we have them for each state, and we can direct you to them. All of us at the Midwest affiliate, we hope that you took away a great deal of information from Dr. Dan DeMoody's presentation. Thank you for taking time from your busy schedule in attending this webinar, and wish you a very pleasant and productive rest of the week. Joe, I think at this time we can conclude.
Today's conference. Thank you all for participating. You may now disconnect.